Thank you very much, and thank you for inviting me. I've changed it a little bit since last week. So anyhow, I'm going to talk about the effects of bariatric surgery and focusing on type 2 diabetes. I'm going to give you my take-home message now and then come back to it, so you can switch off if you've listened to it. So the question I was asked to address is type 2 diabetes curable? Now, we should be using bariatric surgery as part of a toolbox in a polymodal approach for people with severe obesity. But diabetes, type 2 diabetes, is a progressive disease, and whereas bariatric surgery is more effective than anything else in this group, we have to bear in mind that actually, due to the progression, we need to actually use many therapies in order to improve the health of our patients the most. So that's my take-home message. So if you want to switch off now for the rest 20 minutes, then you can. There's my disclosure. So what do I mean by cure? What is remission? So partial remission is an HbA1c of 6.5 or less off medication. So this is the definition that was used in the direct study, so the low-energy diet study. Complete remission is an HbA1c of 6 or less off all medication for a year or more. And if we're talking about prolonged remission, then this is for more than 5 years. So this is a typical patient who I see, Mr. JW, 45 years old, BMI of 50, he's got type 2 diabetes, poorly controlled. He also has high blood pressure, fatty liver disease, obstructive sleep apnea, his joints are giving him jip, and actually for him, life is pretty miserable. He's tried diets, he's managed to go on a diet, lost weight, but unfortunately put the weight back on. So his long-term outlook is not great. This is him 2 years after a Roux-en-Y gastric bypass. He's lost 54.5 kilos, diabetes in remission, off his blood pressure meds, doesn't need his CPAP machine, and overall, he's feeling much happier. Now, Mr. JW exemplifies the problems that come with obesity. Obesity affects every single organ system in the body. In particular, the metabolic complications as a result of the systemic inflammation are the ones that cause the biggest health morbidity. So type 2 diabetes, cardiovascular disease, liver disease, and evidence now for cancer. There's also the mechanical effects of having excess adipose tissue, so obstructive sleep apnea on the joints, stress incontinence. And then we can't forget the CNS psychological impact that comes with obesity and the weight stigma that also comes at the same time. And then we know that people with severe obesity live for a shorter life. So on average, a person with a BMI of 40 will live 8 to 10 years less than a person of normal weight. In terms of type 2 diabetes, as BMI goes up, then the risk of developing type 2 diabetes increases. And this is what is driving the increase in type 2 diabetes in the UK, due to go from 1 in 20 to 1 in 10 by 2030. So why is this? So obesity causes insulin resistance, and then we have prediabetes, metabolic syndrome, and then the far end of this, we have type 2 diabetes, liver disease, and cardiovascular disease. The good news is we know that if we can engender weight loss, then we will improve all of the comorbidities that come with obesity. How much weight a person needs to lose to impact on this depends on the starting point. If you start off with a patient with a BMI of 50, then whilst losing 5% of their body weight undoubtedly does improve their metabolic health, it's not going to improve their obstructive sleep apnea or improve their quality of life. So how much weight you need to lose really depends on the starting point. But in terms of type 2 diabetes remission, we know from other studies and from the direct study that we're looking at about 15% body weight that we need to lose and maintain in order to put diabetes into remission if a person is relatively early on in the progression of their disease. So we do have very comprehensive guidelines for how to prevent and manage people with obesity that have come from NICE, and these are currently just about to be updated. Now, the problem is not weight loss. This slide here shows you many different types of diets, all of which engender weight loss. And patients who come to bariatric clinics will all have lost weight in the past. They will have lost 3, 4, 5 stone, if you're using old metrics. But what happens is we know that over time, the vast majority of people will put all of the weight back on, if not more. And this is really distressing for the people who've managed to do this. Can you imagine losing 5 or 6 stone, everybody congratulating you, and then you put the weight back on? The reason behind that is biology. So in order to keep your body weight at a set point, your brain does this mainly through the hypothalamus and the brainstem. So your brain receives signals from fat, from the gut, and also from your pancreas, which tell your brain how much energy you've got stored and what you've just eaten. Now, from an evolutionary perspective, this was essential. So we have multiple systems that actually encourage us to eat, because we needed to eat throughout evolution in order to survive. If eating was just something you had to do, could you imagine how boring it would be? Well, and part of the way that we've developed to get around this is that eating is incredibly rewarding. And we eat because of the rewarding aspects of food intake. We eat because of social factors. We eat because of food cues. Now, you're going to go for break after this, and I'm expecting there's going to be the lovely, delicious mince pies and caramel shortbread that was here last week. Ask yourself, are you hungry? And I suspect most of you will eat it in the absence of hunger, because actually you're here at a meeting, the college are providing it, and we pay a lot of money to the college. So you have to get the benefit. So we eat because of other reasons, and also genetics. And Sadaf, who I thought was going to speak before me, is now speaking after. She'll talk far more about what we know about genetics now. Now, over the last 30 years, it's become apparent that the gut plays an absolutely critical role in regulating appetite and also blood glucose. And this is part of the reason why most of the pharmacotherapy that's being developed in this area is based upon gut hormones. Many of you will already be using GLP-1 analogues, and this is part of the reason why we know these gut hormones play a key role, both in glucose and in also appetite regulation. I've got one slide on genetics, and this is Sadaf's study, which she'll go into in more detail, that we know that thin people are genetically sort of favored in terms of they don't have the changes in the DNA that predispose to reach for those mince pies and the shortbread. It's not that they're just superior, greater-willed beings. It's just the genetics of that person helps them to avoid them when they go upstairs. And why would we do that? Again, over the course of evolution, it made sense if food was available, we would eat it. And the more energy-dense the food was, then that made more sense. You should eat energy-dense food. So fat, in particular, when you put it in your mouth, feels great. And that's because it's got twice as many calories. We need to eat it. So we've pre-selected for actually eating more when energy-dense food is available. The problem is our environment. Our environment has changed, and now it's possible to eat 2,500 calories in 20 minutes with very little effort and relatively cheaply, and therein lies the problem. The other problem is a diet is the modern-day equivalent of a famine. So again, during evolution, if food was scarce, then we activated a really powerful biological mechanism to make sure that as soon as food was available, you would eat it. And as soon as a person goes on a diet, your body thinks you're in a famine. Why wouldn't it? And that is part of the issue. So as soon as a person goes on a diet, the gut hormones change. There's an increase in ghrelin, which is the hunger-stimulating hormone that acts on the homeostatic and also the reward parts of your brain. There's a decrease in the hormones that tell your brain that you've eaten, decrease in GLP-1, decrease in PYY. Energy expenditure goes down to protect against weight loss. And when we do brain imaging studies and show people on a diet images of food, then their brain lights up like a Christmas tree, because actually you should be eating this, you're losing weight. And the other problem is these changes persist even once you've started to eat again. So you get an increase in hunger, decrease in energy, increase in food, the person puts the weight back on. And that's the biology behind why at the moment, without really prolonged support, most people who go on a short-term diet in a one-year system will do really well, but then they'll put the weight back on. And this is why obesity is now recognized as a chronic disease by many professional bodies. And the Royal College of Physicians earlier this year also called for obesity to be recognized as a disease in order that we can actually give it the sort of health support that people with obesity need. So what about bariatric surgery? I'm not a surgeon. Why bariatric surgery? Well, bariatric surgery alters the gut, which I'll come back to, but we know that it engenders sustained marked weight loss out to 20 years. And if we come back to Mr. JW, we also know that it causes remission or rapid improvement in glucose. So patients who have surgery today will go home tomorrow, the vast majority off their medication. So very quickly in terms of the impact on the improvement in glucose. And also if we look at adolescents, so bariatric surgery in adolescents, this is a story from the States. Again, 95% of these adolescents with type 2 diabetes go into remission after surgery. The effect of changing the gut on glucose is not new. This is a study from 1955 showing that subtotal gastrectomy was curing type 2 diabetes. So we've known for 60 years that actually if we do something to the gut, we can markedly improve glucose. Again, 1995, who would have thought it? Operation, the most effective treatment for type 2 diabetes. Now, when I'm talking about metabolic surgery, I'm not talking about gastric banding. So most people think about gastric banding. Gastric banding only represents 5% of all operations done globally and within the UK. The vast majority of the operations are Roux-en-Y gastric bypass and sleeve gastrectomy. These procedures are laparoscopic. They take 90 minutes, and the vast majority of patients would now be going home within 23 hours or 48 hours. And it works by altering the signals that come from the gut that then regulate appetite, but also regulate glucose control. These operations don't work by just causing restriction or malabsorption. They work because they change the biology of the body. Now, clearly, when the gut is replumbed, we change a whole panoply of different things. We change the gut hormones, we change how much the patient eats, we change the microbiome, we change the vagal signaling. And we don't really know which of these works. But there's a lot of evidence that the gut hormones play a critical role. Well, what about safety? So this slide shows you complication rate, not mortality, in patients with type 2 diabetes undergoing a variety of different operations. And as you can see, laparoscopic Roux-en-Y gastric bypass is right down the bottom in terms of complications and risk. And the mortality rate is about 1 in 1,000, bearing in mind that this is often a very high-risk group of patients in terms of comorbid conditions. Yes, they do develop nutritional deficiencies. Patients need lifelong supplementation and lifelong follow-up, and patients need to be aware of that beforehand. But what about the other benefits? So the weight loss on average is 25% total body weight, but we know that there's marked resolution or improvement, diabetes, hypertension, liver disease, OSA, asthma, reduced risk of cancer, reduced risk of incident type 2 diabetes, and a 30% reduction in microvascular complications of type 2 diabetes, and an overall 40% reduction in mortality. So it's not just the diabetes. But I'm going to come back to the diabetes for the remainder of my talk, because that's what I was told to talk on, and look at the randomized controlled trials comparing best medical therapy with type 2 diabetes for people with obesity. So this trial that's probably the most famous is a STAMPEDE trial, which is best intensive medical therapy, gastric bypass, and sleeve gastrectomy. So patients were randomized to one of these three groups. And basically, the primary endpoint was to get an HbA1c of less than 6%. And the GLP-1 analogues were available at this time, so patients were put onto GLP-1 analogues as they became available. And then the follow-up was with endocrinology, psychology, nutrition, and then follow-up visits thereafter. This is just to show you the baseline characteristics. So the HbA1c in these patients is fairly sort of poorly controlled, and they'd had their diabetes for over 5 years and some up to 10. And if we look at insulin usage, again, about 50% of these patients were already on insulin. These are the 5-year data showing you change in BMI on the left-hand side, change in HbA1c on the right-hand side. And as you'd expect, then patients with bariatric surgery lose more weight. There is a difference between the sleeve and the bypass, with more weight loss in the bypass group. And if we look at HbA1c, again, gastric bypass and sleeve gastrectomy are significantly better in terms of HbA1c reduction than intensive medical therapy. What about drugs? So if we look 5 years on, only 2% of the medical group are not on medication, which is what we'd anticipate. 45% of the bypass, 25% of sleeve gastrectomy group are off all medication with an HbA1c of less than 6%. And again, if we look at insulin, 40% of the medical group on insulin, only 12 and 11%. So that's a huge reduction in terms of the drug burden to the patient. So it's not just the STAMPEDE. These are 11 RCTs, all of them favouring surgery in terms of glycemic control. Well, what about durability? So this is a study published in 2017, again, looking at remission rates. 75% 2 years, but still 50% of patients off all treatment 12 years after a Roux-en-Y gastric bypass. These data are from the LAB study, which is a study in the States looking at 2,500 patients, and again, similar sort of remission rates out to 7 years. And the dark blue is people who developed incident diabetes. But what we do know is that the longer you've had your diabetes for, then the less likely you are to have remission of your diabetes when you have surgery. So for people who've had diabetes for 15 years or more, then the remission rates are much lower. Now, why? Well, we all know that we need insulin resistance and beta cell failure in order to develop type 2 diabetes. And we know that type 2 diabetes is a progressive disease. So there seems to be a sort of a sweet spot where we need to actually operate earlier rather than leaving it to later if we are going to help patients to achieve remission for a durable period of time. And the LAB study, which is a study that I showed you a few minutes ago, have done some mechanistic studies trying to look at how is the surgery working. And they've done this by comparing people with and without type 2 diabetes, age and sex matched and BMI matched them. And in order to be in the type 2 diabetes group, they had to be controlled on either a sulfonylurea or metformin. So they did quite a lot of studies. They had a frequent sampled IV GTT to look at insulin sensitivity. They also wanted to look at glucose disposal. And then they also did meal studies looking at proinsulin and also gut hormones to compare these two groups. If we look at weight loss, again, weight loss in patients with type 2 diabetes is fairly similar to people without type 2 diabetes. If we look at changes in GLP-1, again, fairly similar increases, this is after surgery compared to before, in patients with diabetes and without. And as you'd anticipate, at baseline, the patients with diabetes have got higher proinsulin levels, but these all come down. And if we look at changes in deposition index, these are the controls. And again, if we look in people with diabetes, again, an improvement in both groups. So what did the mechanistic studies show? They showed that insulin sensitivity improves directly proportional to weight loss, but also that the beta cell insulin secretory response improves. And it improves sort of in both groups, but by a different mechanism. And what happens if you look at the people who don't have remission of their type 2 diabetes. So this is what this shows you here. The patients with remission can increase their insulin, but the people without remission are unable to increase their insulin secretory response after the surgery. So even though you're reducing the insulin remission, the beta cell is unable to increase its secretory response. So if we compare the RCTs, the take-home message is you get better weight loss, better glucose control, higher type 2 diabetes remission rates, and a lower drug burden in patients who have bariatric surgery. But timing here is absolutely critical, because if you leave it too late, then you lose the benefit. So NICE recognized this, and they recommended that a person with severe obesity with type 2 diabetes of less than 10 years should have an expedited referral for assessment for bariatric surgery. And this was based on the knowledge that we knew that timing was important. And also to consider this for people in a lower BMI category, and also because Asian patients are different in terms of their metabolic risk, to reduce this by 2.5 BMI points. This has also been followed up by global recommendations. But what happens at the moment? Less than 1% of all people in the UK who are eligible to have bariatric surgery with type 2 diabetes are actually having bariatric surgery. So what are the take-home messages? Bariatric surgery at the moment is the most effective treatment for people with severe obesity, so BMI over 35 or more, in terms of weight loss, improvements in type 2 diabetes, but timing is absolutely critical. Type 2 diabetes is a progressive condition, and we're going to need to use adjuvant pharmacotherapy, even in the group that have had bariatric surgery. And it's important to tell them that yes, your diabetes is going to go into remission, but you still have all the risks that have been with diabetes, plus also it is likely that in the future, your diabetes will come back. And what we need to do is move away from sort of the surgeons versus the physicians to actually combining it all together and thinking what is the best possible approach for treating our patients. There are my acknowledgements, and thank you for your attention.